Clinical Pearls brought to you by Medicom Oncology.
Hello, I'm Dr. Pinkal Desai, leukemia physician at Weill Cornell Medicine and New York Presbyterian Hospital. I really believe that that AML is not a one disease state. It is so heterogeneous. There is so much variation within one patient versus the other on all of these cytogenetics and molecular risk. It is very important that these risks are defined ahead of time. It's important for a variety of reasons. So everybody who has a newly diagnosed leukemia should have obviously a karyotype or cytogenetic risk identified and the test done. In addition, there has to be a molecular profile that should also be done at diagnosis. And this is important for several reasons. The first one is selecting the treatment itself. So there are certain mutations that are targetable and that are approved drugs for it for a newly diagnosed upfront setting, for example, midostaurin. So it's absolutely important that we know whether somebody has a FLT3 mutation or not. And there are several other targeted treatments that are coming up in clinical trials. So it's important to identify that at baseline as well. And patients should obviously be encouraged to join any of these trials because those are the key things to improve survival in patients. The second reason why this molecular risks and identification of these individual molecular profiling is important is to figure out what to do after a patient goes into remission. So it's not just the upfront induction treatment that would matter, but also what we do after the patient is already in remission. Because depending on these molecular profiling and cytogenetic risk, we would make individualized, or one should make individualized decisions on whether somebody should be consolidated with allogenic stem cell transplantation or should they receive more consolidation in the form of chemotherapy. And that distinction is completely based on these molecular and cytogenetic risks. And I would argue that getting into remission is just like part of the work in AML. In fact, most patients who have AML and are in remission still have some amount of residual disease. It's just not identifiable on regular morphologic testing. So it's important that the right consolidations follow the remission in order to increase the chances of cure. And these molecular classifications help us identify what patients are more likely to relapse. The third reason why these mutations may be helpful, and this is an upcoming thing and is not currently the standard in AML, but I believe would be at some point, is some of these mutations, for example, NPM1, and also some of the proteins that we could identify, for example, the core binding factor leukemias, there is a push towards monitoring them over time, even in remission, and what we call MRD testing or measurable residual disease testing. Because if you know that a patient has a particular mutation and we determine that that mutation is one of those founder mutations and could be prospectively monitored, that helps us understand whether somebody is going to relapse. And if we see that these mutations could be followed over time and that their transcripts are rising, that will help us understand, okay, this patient is more likely to relapse. Should we do something at this point in order to prevent the oncoming relapse? So I think that these molecular mutation profiling and personalization of care is extremely important for not just upfront treatment, but also consolidation and also eventually monitoring these people after all of the treatments are done. And I would strongly feel that these should be always done.
Don't forget to subscribe to the Medicom Oncology podcast channel for more clinical pearls. And be sure to visit managingaml.com for more practice resources.